Hey guys, I just wanted to do a quick video on some things I learned this week. This is basically just stuff that I wrote down while I was in the hospital, and I thought it'd be fun to just kind of keep track of over time. And if you guys have learned anything, maybe it would be cool to put that in the comments or something like that. So let's just get straight into it. So the first thing is, when should you get an ABG after making a ventilator change? That would be around 30 minutes later, so you can see the effect of the changes you made on how the patient is doing. What is your goal PaO2 in intubated patients? It would be above 55 basically, or anywhere from 55 to 80. I'm sure you all remember that oxygen dissociation curve, with an ideal O2 sat of 88 to 95%. In intubated patients, FiO2 should be decreased below what value first before decreasing PEEP? And I learned this week that normally they like to get it a little bit below 50% before they start considering decreasing the PEEP. And I'm not sure if this applies for everything, but basically for one of the patients we had this week, this is what we did. What antibody can you test for to evaluate for membranous nephropathy? That is the anti-PLA2R antibody. On electron microscopy of a kidney biopsy, subepithelial humps suggest what condition? That would be post-infectious glomerulonephritis. And I just thought this was nice. This came up in a noon report, and I felt like a lot of times on UWorld, they would test us about these subepithelial humps, and I would always forget what they actually were kind of indicating with that. But now I feel like I'll have a more solid understanding of that. What three main conditions should be on your differential for nephrotic syndrome? That would be minimal change disease, FSGS, and membranous nephropathy. And then what three main conditions should be on your differential for nephritic syndrome? That would be immune complex mediated, including lupus and post-infectious, ANCA mediated, and anti-GBM mediated. So this is going to be really helpful because now I have two large buckets of nephritic syndrome and nephrotic syndrome, and I have three main categories of diagnoses for each. And that's going to make it a lot easier than going on UpToDate and seeing those huge lists on everything. What is a good third-line pressor to use in a patient with bradycardia? That would be epinephrine. We had a patient who basically was in shock and their heart rate was only in like the 70s. And we thought in order to augment their cardiac output, epinephrine would probably be the best next pressor to add on after they were already on norepinephrine and vasopressin. What organ clears lactic acid? That would be the liver. So if anybody has liver dysfunction and they're having a worsening lactic acidosis, that could be one contributing factor. And also if they just have liver dysfunction, but you don't think they're poorly perfusing or anything, then you could start to attribute it to type B lactic acidosis rather than type A lactic acidosis. Low platelets and renal failure should make you immediately concerned for what conditions? That would be TTP and HUS. What is the treatment for TTP? That'd be plasmapheresis, and this was again during one of our noon reports, and I had thought it was steroids, but actually you go straight to plasmapheresis apparently for TTP. What are the best EKG leads to assess QT interval? That'd be leads 2, V5, and V6. Obviously, we usually just use the calculated QTC from the EKG machine, but I thought it was kind of useful to know which leads were best for identifying this, because sometimes you do have to manually calculate it. For example, if somebody's an AFib or if they have a wide QRS, those are times where you're actually supposed to manually calculate the QT interval, which I didn't know before. How should you treat a Q wave in lead 3? So Q in lead 3, let it be. So if somebody has a Q wave in lead 3, you don't have to be super concerned about it unless they have other concerning EKG findings. How can propofol affect the appearance of urine? It can cause green urine, and so this is something that nurses might page you about, although ICU nurses probably already know this at this point since they've been working for a long time. But notably, the presence of green urine does not suggest a further suspicion for developing propofol infusion syndrome. A wedge-shaped opacification on a chest x-ray might suggest what process? That would be atelectasis. So here's just an image of some different regions of atelectasis affecting different parts of the lung, and you can see there's always like a wedge shape and it points to the hilum. So if you look how it's like that, not so much for this one, but if you look at an actual chest x-ray, you'll see how it's kind of this wedge where it points to the hilum here. And for this density here, this right lower lobe density is also kind of triangular shape going like that. Obviously, you can have Hampton's hump too, but that's more of a peripheral wedge-shaped opacification. If it's more like this, going to the hilum, that can suggest like a mucus plug that's blocking that and causing collapse of the distal lung. So that was a few of the things that I wrote down of stuff that I learned in the hospital this week. Hope you guys enjoyed, and let me know what you guys learned in the hospital this week. And thanks for watching.